Welcome to today's webinar. Thank you for attending our webinar today on telemedicine program funding and sustainability, brought to you by AMD Global Telemedicine, University of Kentucky, and Telecare and Denison Associates. We are here today to help make people aware of the grant programs available for telemedicine and how to move forward with your telemedicine programs. We want to help you learn how to cut through all the noise and help you make the process simpler. Today's featured presenters, Kathy Denison Robert, the president of Denison Associates. She's going to be talking about grant funding, giving an overview, walking you through the grant application process. And Rob Sprang, director of Kentucky Telecare, co-project manager, Kentucky Telehealth Network. He's going to talk about program sustainability and the value proposition of telehealth. If you have questions during the webinar, feel free to enter them into the box on the right-hand side of your screen. There's a panel that says questions. All you have to do is type in your questions there. What we'll be doing is collecting all the questions, and then at the end of the presentations, we'll have a 15-minute Q&A session where we'll read off the questions you typed in and try to address as many of them as possible. However, if we don't get to all of them, we will be providing you all with a summary of all the questions and answers following the webinar. And very important, please write down this number in case you have any problems connecting with this webinar. The technical support number is 800-263-6317. So first, Kathy's going to speak about the overview of grant funding. So she's going to discuss grant funds that are available specific for telemedicine programs, common reasons why funding proposals fail, and key components in the application process. Kathy?
Good afternoon. I'd like to thank you for joining us for this webinar, and I'll offer special thanks to AMD Global Telemedicine for coordinating and facilitating this telemedicine webinar. It's my pleasure to be a co-presenter with Mr. Rob Sprang. Together we will try to provide you with a brief overview of telemedicine grant funding and sustainability. Please understand that both of us have topic areas that might easily be entire weekend seminars, so we will be providing you with just some key points today. If you're looking for ways to fund your telemedicine or telehealth programs and projects, then I will assume that you have done your research and you've done your homework and you know that you have a problem or problems to solve, a need to be addressed, or issues that should be handled. Before seeking grant funds, you must have your problem or need clearly identified, and you're now looking for ways to fund your project to help solve the problem, expand your program, or improve upon the issues. Billions of dollars of funds are available for telemedicine projects from foundations, private sponsors, local, state, and federal agencies. Many organizations miss out on beneficial funding because they don't have appropriate resources to plan, develop, write, track, and manage the grant process. Today, we will start with an overview of some telemedicine funding sources. USDA Rural Utilities Service Distance Learning and Telemedicine Grant Project or program is DLT. This is known as DLT. HRSA's Office for the Advancement of Telehealth, better known as OAT, has a Telehealth Resource Center grant, and OAT also has the Telehealth Network grant program. Universal Service Administrative Company, known as USAC, has the USAC Telecommunications and Rural Healthcare Program, and these are discount programs. The United States Department of Commerce has projects like NIST and NTIA. CMS offers Healthcare Innovation Awards. There are research and innovation grants. There's some like NIH and SBIR. In addition to grants that are specifically designed for telemedicine, I recommend that each applicant should think outside the box and look for funding sources that are available in your area of interest and see if telemedicine technology and software might be able to be included in those grant programs. For example, mental health grants that might include telepsychiatry in the grant proposal. Also, besides mental health, there's rural health, children's health, school-based telemedicine, distance education grants, senior health, and broadband projects, just to name a few. Other funding sources are state associations, state agencies, your state government, and some international organizations. Be sure to contact foundations and private donors, insurance agencies, and healthcare systems. And also consider visiting with technology, telecommunications, and software vendors about grants and discount programs that they might offer you. Before we review some key components in the grant application process, let's stop and discuss some common reasons why funding proposals and applications fail. After reviewing resources from numerous sources and talking with reviewers and funders, here are some common reasons why funding and grant proposals or applications fail. You did not apply to the appropriate funding agency. The directions and the deadlines were not followed. The outcomes are not measurable. The applicant did not demonstrate fiscal accountability. And don't send out lots of applications like form letters or form applications, but instead take the time to customize your proposals to each funding agency to avoid a scattered or shotgun approach. Other reasons why proposals might fail: your methodology appears flawed, poor grammar, spelling errors, incorrect fonts or formatting. Organizational readiness is lacking, or to the grant reviewers, it appears that the organization is not strong enough or ready to handle the grant funds. Your budget is problematic. Remember to double-check your math. The applicant is not even eligible for the grant that was applied for. And you did not pay attention to the scoring criteria. Please thoroughly review and study the scoring and the evaluation criteria for each proposal that you submit. Once you've identified a funding source and grant application, be sure to read through and study all grant proposal guidelines, rules, regulations, and tips. Read through past success stories and grantee abstracts. Be familiar with the types of projects that the funding agency is planning to fund. And please pay special attention to timing and due dates. Developing grant projects takes lots of time and can't be done overnight. Federal grant proposals might take a couple or even a few months to develop competitive proposals and application packages. And since every grant is different, it's very hard to come up with one set of key components in the grant application process. Some foundations or state programs have a common grant application that has similar components for many of their funding agencies. in your search engine, put in Common Grant Application and see if your funding source utilizes a Common Grant Application format. Today, I will provide you with some common sections in the grant application process, and will also mention the main components in the USDA RUS Distance Learning Telemedicine Grant that is coming up very soon. Now, some key components. Number one, in your introduction, provide some brief background info and your mission. Number two, your executive summary or your project summary. Most proposals begin with a project summary, an executive summary, or an abstract that summarizes the key points in the grant proposal. Identify the problem statement or statement of need. This is probably one of the most important sections, and many reviewers and funders state that this is usually the weakest section. This section can be strengthened by including objective data and information. Number four, goals and objectives should be based on issues or needs that were addressed in the needs statement, and be sure they are measurable. Number five, benefits of the project. Be prepared to clearly describe your project's benefits. Number six, the statement of work and project timeline. See the funding agency's requirements for describing your scope and for submitting a project timeline with milestones. Some other components in the application process. Number seven, be realistic and provide budget details in the proposal budget. Don't submit a budget that is over the funding agency's allowable budget amount. Include real figures and don't try to pad the numbers. It will be noticed. And again, be sure to check your math. Number eight, the management team and personnel. Always include bio information on your management team members and the key project personnel. Number nine, partners, collaborators, supporters. Most grants do require collaboration and partnerships. Funders want to know that the end users and supporters are standing with you in your project efforts. Many times support letters are very helpful. Number 10, the evaluation. Describe the project's overall approach to evaluation and how will your results and your project outcomes be measured. You want to demonstrate to the funding agency that you are willing to be held accountable for what you propose in your project. And number 11, finally, the supporting documentation and attachments are usually required in an appendix. The USDA Rural Utility Service Distance Learning Telemedicine Grant Program is very competitive and is an extremely complex proposal to develop and to write. Applications are scored in objective and subjective categories. The USDA RUS Program Office will probably release that grant announcement by the end of April or early in May. Then usually there's about a 60-day window before the grant deadline. Therefore, if you're planning to develop an RUS DLT project this year, then please consider starting the grant development process now in order to have time to submit a competitive proposal package. In addition to basic key components previously listed for applications, the RUS DLT grant also includes the following sections: a telecommunications system plan, financial information and sustainability plan, And later, Rob will spend some time telling us some beneficial sustainability information. Provide a statement of your experience. When we're looking at the objective scoring sections, we're talking about rurality, economic need that's illustrated by the National School Lunch Program, and leveraging. And leveraging is describing the matching funds. Other key sections in the RUSDLT grant are innovativeness and cost-effectiveness of the project. And lastly, other federal funds and many certifications will be required. I've included some resources here that might be helpful for you. The Foundation Center, Catalog of Federal Domestic Assistance, we have HRSA, Universal Service, and others listed here. In closing, the grant process can be overwhelming, and there are many resources available to assist you. Some funding agencies provide training seminars, webinars, and technical assistance sessions to assist with the grant development process. Be sure to take advantage of those educational initiatives. And should you desire to hire a professional to assist your team, I highly recommend, especially if you are new to the grant development and grant writing industry, that you hire a professional who is experienced with not only developing and writing grants, but a professional or professional organization that's been in the field and has successfully implemented projects, managed grants, and has even been a grant reviewer. Here's my contact information. Feel free to contact me if you have questions or if you need any assistance. I want to thank you for your participation today, and I hope that I've been able to provide you with some useful information. Thanks again, and wishing you the best.
Thank you, Kathy. And now I'd like to introduce Rob Sprang, who's going to talk about telemedicine program sustainability and the value proposition of telehealth. He's going to help walk you through how to position your telemedicine program that will build a value proposition, and very important, how to develop a sustainability plan. So what happens when initial funding runs out?
Thank you, Carrie, and well done, Kathy. It was a great overview on the options for external funding. And as difficult as it is to secure funding, it's just as challenging to keep a program sustainable. And so I hope as I talk to you today, we can make a little bit of headway in how you can do that for your program. The objectives of the program are to talk about the difference between a project and a program. What is the role of telehealth in a healthcare system? Talk a little bit about the return on investment with telehealth. And then the volume versus value proposition. How does reformed healthcare system help with sustainability of a telehealth program? And then specifically, will my model, or the model that I use, will that work for you? Because if it doesn't, certainly we can adjust that model for you. Many telehealth programs started with grant funding, and for most of us that began in the mid-1990s. And we were consumed with launching our new grant projects, struggling with the technology, fighting the legal and regulatory issues that threatened our programs. And we couldn't see beyond our initial funding. We were all on borrowed time. Sustainability was often measured in days and not years. Telehealth was often considered a mission, and I don't mean as in a mission statement, but telehealth was considered missionary work to reach out and bring healthcare resources to those that didn't have access normally. But there's an old saying, no money, no mission. And so you must look for opportunities to generate revenue that will help subsidize the mission work that you'll most assuredly take on in your program. Let's talk a little bit about a project versus a program. And it's critical that you put a grant into its proper perspective. As you're launching a new telehealth initiative, or are you adding sites or services to an existing initiative, it's easy to consider a grant as a project, but a project like a grant has a beginning, an objective, and an end. And while a program is an ongoing, sustainable effort that may have milestones, but it doesn't have a planned completion date. You must think of your telehealth initiative as a program and not a project, if for no other reason than when a project is completed, you have to move on. And in this case, you have to go find another job. So a telehealth program can initiate a project, but the cumulative effect should be an ongoing program that continues to build upon itself. A grant should provide the funding to launch a new program or a new project that strengthens an existing program. What's the role of telehealth in a healthcare organization? You've got to have a clear understanding of what is valued in your organization and then figure out how can telehealth technology benefit the organization by supporting the mission, goals, and objectives. And you don't want to make any assumptions here that you understand your organization's mission and goals, because you may fully accomplish the goals that you perceive only to find out they don't support or align directly with your organization's goals, and you won't be perceived as having provided any value to the organization. So if you are in an academic medical center, you want telehealth to support the missions of clinical service, to extend healthcare resources without your providers having to travel. You want to support the mission of education so that trainees, providers, patients, family caregivers are able to access educational programming without your faculty and your resources having to have expensive and sometimes dangerous travel. You want to support the mission of research, which is to attract funding and provide research opportunity. And then finally, you want to support a mission of administration, which is just simply reducing travel for meetings and maybe offering marketing and PR opportunities that wouldn't be available otherwise. Now, if you're in a community hospital, you want to use technology to connect to referring clinics so that you can reach more patients. You can also import specialty care to keep your patients local and not traveling away from the community. The technology can also provide you a public relations and marketing opportunity. And if you do your job well, you can keep more patients, more healthcare revenues, and ancillary healthcare services in the community. Now, if you're in a community clinic, you could reach into public schools to deliver care. You could import mental health and specialty services that are not available in your community. And the technology can help position yourself as the first choice for healthcare in your community. Now, return on investment. This is always a difficult issue to deal with. Calculating return on investment is a difficult task, and so I try to focus on developing value for my medical center. Telemedicine can generate revenues, including a professional fee for your provider, facility fee to the location where the patient is seen, and it may offer other opportunities to generate contract revenues for clinical and educational programming. But one thing to consider, does this revenue accrue to the telemedicine office? In my program, these revenues pass straight beyond the telemedicine office and go to my providers and the healthcare system, and I don't take a cut of this funding. Now, there are expenses associated with a telemedicine program. The consulting site has capital expenses for equipment, ongoing maintenance, communication networking, and costs for administrative and operational staff. The referring site accrues capital costs for equipment, ongoing maintenance, communication networking, administrative operational staff, and the clinical presenter that works directly with patients. So if you look at my program, we have expenses, but we have limited revenues, at least not revenues that come to my office, because the providers keep all their clinical revenues generated with telehealth. That may not be an option in your program, so you need to consider that. There are also other considerations that impact healthcare revenues and expenses that can be addressed with telehealth technology. A hot item for many of us right now are readmission penalties, and they're always a concern for hospitals, and telehealth can have an impact there. If you're in an accountable care organization where you offer a shared risk and reward opportunity so that your organization's investment in technology that can address the triple aim goals will result in improved revenue for your organization. We all struggle with the overutilization of emergency rooms, and how do we drive people back to appropriate levels of care? Technology can offer some help. And in my hospital, which is often full and is often on divert, it's critical that we keep non-urgent medical cases out of the hospital, keep them in community hospitals to make room for surgical, procedural-based patients that must be at our medical center. Telehealth can help us keep more patients in community hospitals to allow more room for the patients that require quaternary care. The financial incentives for healthcare innovation don't always align with stated goals in a value-based healthcare system. We're all concerned with reaching the triple aim outcomes of improving patient experience, increasing population health, and reducing per capita cost of health care. But if you're not in an ACO or another pay-per-value model, every dollar saved is a lost dollar of revenue for someone. Once we're in a fully reformed healthcare system, the goals of the system and the incentives will align properly, and we'll all be properly incentivized to do the right thing. So what should you do now? First and foremost, pursue high revenue opportunities. And again, you have to balance that with what we talked about early, the mission work that is often considered with telehealth. Contracts with industry and corrections and others who are self-insured, so-called concierge medicine, are great opportunities. I've positioned telehealth in my organization as a cornerstone of these very lucrative opportunities. And without my technology, my medical center would not capture that larger revenue from those contracts. Another thing to consider is losing less money. And that may not seem like a great aggressive target, but as readmission penalties and other penalties are tied to quality measures, we will have increasingly significant impact on our organization. Technology is going to be a critical tool to monitor chronic disease patients or recently discharged patients in their homes and avoid these ever-increasing penalties. And then you need to consider low-cost technical solutions and mobile solutions. There's an increased demand for more personal technology, the bring-your-own-device concept, and consumer demand is driving the development of services that address acute episodic health problems in the home, keeps people out of the emergency room, but it may even bypass local physician practices. And so there's a lot of legal and regulatory and maybe even ethical issues surrounding this. Some of these programs may not be grounded in good medicine practice, but you've got to be aware of this trend in the healthcare delivery to drive healthcare to the patient. And then focus on solutions your organization will value and be prepared to modify your efforts as the market changes or as you learn from your experiences. I know a large health system that used grant funding to launch an electronic ICU program to regional hospitals, and they were quite successful. But once the grant funding expires, the business model failed, and they repositioned their efforts using that technology to support their own institutional ICUs, and that made a very good business case for them. Most importantly, I want you to make telehealth necessary infrastructure in your organization. Now, the model that I built, we talked about a little bit, is that telehealth at the University of Kentucky is the foundation of a $20 million a year clinical contract. None of that money comes to me, but my hospital providers and clinic benefit from those revenues. And without my program, which is a fraction of that, believe me, a fraction of that $20 million contract, I don't believe that the university would have that contract. Also, as an academic medical center, we send students and residents across the state for clinical training, and they're more likely to remain in a rural practice, which also accomplishes one of the missions of a land-grant medical university. Our goal is not to train doctors to travel all over the world. Our mission is to train healthcare professionals, doctors, nurses, pharmacists, to practice in our state. And we know that if these students and trainees have an opportunity to practice and learn in a community-based practice in our state, they're much more likely to remain here. Telehealth helps fulfill my pediatrics specialist mission for a state contract to deliver regionally based outreach clinics, and we're able to use technology to reduce unproductive travel that's required to traverse across the state. I've already talked a little bit about a lucrative industrial health contract that helps us recruit highly specialized surgical, cancer, and interventional services to UK from a large mining company. We developed a telehealth program that reaches every one of the facilities across the country, and that organization is now able to connect to specialists from the workplace itself. So it creates revenue for my organization, but again, it doesn't necessarily create revenue from my telehealth program. And then finally, there's a great opportunity for administrative meetings to be done using video conferencing. There is a clinic system in our state that is made up of 8 primary care clinics. None of them are more than 45 to 60 minutes away from one another, but they're part of several collaboratives. They're part of the diabetes collaborative, a congestive heart failure collaborative. These require all hands-on-deck physician meetings 1 or 2 times a month. We did a study of those 8 primary care clinics that had video conferencing capability. When they started using the technology to bring those meetings together, we looked and found that there were hard costs associated with just paying for travel, but there were also soft costs. The opportunity cost of putting a physician or other provider staff on the road when they could be in the office being productive. And we found that those clinics saved $186,000 a year in travel cost and lost revenue opportunities by simply replacing in-person meetings with video conference meetings. So, you've got your grant, you've deployed the grant, it's the end of the grant now, and you're going into your first budget meeting after the grant has expired. I can tell you at the University of Kentucky, I've sat through nearly 20 years of budget meetings. And many of those meetings, many of those years, I didn't have a grant. I never heard someone in a budget meeting ask the question, how much revenue did the air conditioner generate last year? And yet every medical center is air conditioned. Your goal is to make telehealth necessary infrastructure. The term political capital is one that I like to use, that if you create value for your organization, you will build political capital with your leadership. Your goal is to find every way possible to leverage your program for the benefit of everyone you touch. Make others look good, make your organization look good, make those who partner with your organization look good, and you improve your chance for long-term sustainability. I hope that you found that this presentation gave you a little sense of sustainability. Believe me, in my case, these are lessons that have been learned over 20 years. And so I think that we'll throw it back to Carrie, and we may have an opportunity for questions and answers. So thank you all very much.
Thank you, Rob and Kathy, for sharing your thoughts and personal experiences with us today. In closing, before we move on to our Q&A session, I'd like to remind you of the importance of choosing the right telemedicine equipment and technology for your specific application. When putting together your grant applications or improving on your current telemedicine programs, make sure you think about the specialties you plan to service as well as the environment the equipment will be in. This will help you define the products and the technology that you need and eliminate purchasing equipment that won't get used. AMD Global Telemedicine specializes in helping our customers define the telemedicine products that fit your needs, such as clinical telemedicine systems, medical devices, and encounter management software. Here's my contact information as well. Feel free to contact me if you have specific questions about AMD Global Telemedicine products and technology or about this webinar. Now we can start on a lot of the questions. We've been getting some coming in actually throughout the webinar. We also got quite a few come in when you signed up. So I'm going to start going through some of these questions first. While we're going through these, if you have questions and haven't asked it yet, feel free to use that control panel on the right-hand side of your screen where you can enter your question in. So the first question, I think, will be for you, Kathy. Are there funding sources that support institutes that are involved in building international presence and collaborators for telemedicine equipment and support services?
Oh, good question. Most traditional U.S. federal funding is not for international telemedicine. You might contact vendors directly, or foundations or private donors. I would also recommend you talk to some international healthcare funders like the World Health Organization. I'm not sure about USAID, some of the others that are international and fund healthcare, and try to put together a proposal and convince them to consider funding telemedicine.
Great. Thank you very much, Kathy. The next question here, I believe, is for you, Rob. How easy is it for rural clinics to adapt and own the process after project funding ceases? And what is the viability and how to improve it?
How easy is it? It's not easy at all. If it was easy, everybody'd be doing this. And every organization is going to be different. What I can tell you, I mean, it's always going to be a challenge to change the way providers do health care. But what I can tell you is that I would much rather be building a program today than I would 20 years ago, because people are familiar with telehealth now. It is much more recognizable. You know, very few doctors don't have an iPhone or an iPad, so they are much more technology literate than they would have been many years ago. The key to this is creating value, recruiting appropriate stakeholders in the leadership realm. We have one of our best telehealth partners has great buy-in at senior leadership, and in fact the senior leadership has used telehealth to be seen by medical specialists at University of Kentucky. That's the kind of buy-in that will create value, that will bring people to the program. So no, it's not easy, but if you persist, you can make it work.
Okay, great. Next question, let's see. Is grant funding mostly geared toward large health systems, or is there grant funding available for community-based multi-specialty medical groups with core services of primary care? I think Kathy?
Okay. I'll start that, and maybe Rob can add. Each project is different. Each grant program is different. And many times there are rural health programs that provide funding for rural primary care. Particularly the RUSDLT does focus on rural primary care. So that would be one. And large health systems or small or multi-special medical groups that have core services for primary care are all eligible to be in different types of grant projects and might be different alliance partners or collaborating partners. So I would say in your case, I'm not quite sure who your medical group is, but it is rural. One that's coming up is the RUSD-LT project.
Great. Thank you, Kathy. And Rob, I think this question would be for you. My client has an ongoing consumer-focused telemedicine service. They are concerned about financial sustainability in the Obamacare future. Any suggestions regarding positioning and marketing and potential grant opportunities?
I would ask that we rephrase this. Obamacare has been so politicized that some people really can't see beyond their political leanings as it relates to Obamacare. What I would like for you to think of what is happening is not Obamacare, but a truly reformed healthcare system. Not a system that incentivizes us for volume, because in the past, and for many of us today, you get paid on the amount of volume of work that you do. So if I want to make more money, I see more patients. If I work harder and do more procedures, I make more money. But in the future, call it Obamacare, call it whatever you want, we are going to move to a pay-for-performance system. And that runs counter to a lot of what we've done for many years. Our job is going to be to keep you out of the hospital, to keep you out of the doctor's office, to manage chronic disease before it becomes an acute problem. And so it is going to change the way we do business. What I can tell you, for people in telehealth, I think our ship has come home, because that's all about telehealth, getting the right care to the right people at the right time in the right place. And I think that we will be, often we have struggled to make telehealth work because traditional reimbursement models may not have fit telehealth. But in a reformed healthcare system where you are paid for outcomes, you are paid to keep people well, that should be right in our wheelhouse. So I think for all of us in healthcare systems that do telehealth, reformed healthcare is the best thing that's come around for us.
Okay, great. Next question. I think this is for you as well, Rob. We have used several grants to kick off initiatives, but have found barriers around physician engagement and recognition of the value add of telemedicine.
Well, it kind of goes back to the other thing. Is it easy? And no, it is not easy. You just have to work. You have to be persistent. You have to believe you're going to prevail. I often compare the healthcare system or the healthcare industry with the banking industry. I mean, we just take it for granted that we never go to the bank anymore. Look, I'm old enough to remember you got paid on Friday and you took your check to the bank to deposit it. That was before the drive-through lane. So we are going to change healthcare to some extent the way we changed the banking industry. We are going to make access to healthcare maybe ubiquitous so that you can access healthcare from anywhere, just as you access banking from anywhere. There are going to be some people that reject this and that don't want to adopt this. Frankly, they're going to be left behind. But today, right now, you have to be persistent, you have to be creative, and you have to build that value model for people so that they will come around.
Okay, great. Kathy, this might be one for you. We have a program, but are looking for financing opportunities for upgraded equipment. How can we go about doing that?
Okay. You have a program, but you're looking for financing opportunities for upgraded equipment. If we're looking at federal funds, again, the RUSD-LT project, Distance Learning Telemedicine Grant, does allow equipment funds, grant funds for upgrading equipment, expanding your programs. It's can't duplicate your services or your technology and equipment costs. Nothing can be duplicated, but they do allow for upgraded equipment. You might also consider foundations. Talk to the vendors that you're trying to upgrade the equipment with. Specific, certain vendors might work with you, and of course, private donors.
Okay. And Rob, we utilize telemedicine through the state of Louisiana program. Some services are not covered. Where can I find specific information on emergency room services and OB service?
I feel your pain. Again, I started the program back in the mid-90s when nobody reimbursed for telehealth encounters. What I can tell you today, emergency room services and OB services should be completely reimbursable by Medicare. Of course, private insurance and Medicaid are going to be state-by-state decisions. And I'm not sure where you would look. You may go to your state medical board in Louisiana. You may talk to other people. I'll be glad to talk to somebody offline, and I might be able to help you get some information through organizations that I know. But if you find out that there are services that are not reimbursed in your state, especially Medicaid and private insurance, then you've got to be a catalyst for change. You've got to make this happen. I mean, believe me, that is not easy work. We wrote legislation in my state in 2000 that mandated Medicaid and commercial reimbursement for telehealth encounters. The language was great. The regulatory language that followed behind it wasn't so good. And so what we were able to do was enact changes in the regulatory language, which took us 7 years to change. It is not quick, it is not easy, but it's necessary.
Great. Kathy, what are the available grants for private or profit telemedicine companies? Is there an available list somewhere or a place I can look?
Okay, say that first part again. Private or profit?
Okay. Yeah, what are the available grants for private for-profit telemedicine companies?
Okay. Well, as I mentioned earlier, private for-profit telemedicine companies can be included in many federal and state health care grants, just like the other provider, but in many cases, for-profits be included as a consortium member or an alliance member in the project, but in most cases, a private for-profit can't be the lead agency or the fiscal agent, but they can be included in grant projects.
Okay, great. Rob, this one's for you. We would like to hear ideas on how public health can be more engaged.
I think public health may offer one of the best opportunities we have across the country in telehealth. With shrinking budgets, public health is under attack right now. I certainly know in our state every year public health takes a hit, and our public health departments are trying to reinvent themselves. Long ago, public health departments were the safety net where everybody went with no insurance. And then they became very focused on the issues of population health. And now what you're seeing is that public health departments are having to reinvent themselves just to survive. And so they are often open to new ideas. And I just got back from a conference where we had many people from Kentucky. We had almost 20 attendees. And we had a kind of a public sit-down session with just the Kentucky folks, and we came up with an idea very much tied to public health, where we're going to do ongoing diabetes education programs that are going to include many public health departments and leverage the resources of those public health departments. So I think if you sit down and talk to your public health departments, they're going to be looking for how do they survive and thrive in the new world of healthcare. I think there'll be a great opportunity for you to work with them.
Okay, perfect. And let's see. Here's another one. Not sure. I think this might be you, Rob. Under the new Affordable Health Care Law, is there a requirement for insurance companies to cover telemedicine? And where can we get information on the insurance coverage for telemedicine?
I am not aware of anything in the Affordable Care Act that mandates coverage for telehealth. I do know they speak of telehealth. And again, and you've got to really think through the model and the concept of affordable care, and again, the movement to a pay-for-performance model as opposed to pay per volume, pay per activity. Our job is going to be to keep people well. And so it doesn't matter how you do that. Whatever you do will become, in an accountable care organization, a reimbursable service. There are organizations like the Center for Telemedicine and eHealth Law, the American Telemedicine Association, that can help you find out some of the state level and Medicare and even federal Medicare level reimbursement issues. And I'm glad to help you guys with that. So if anybody has questions about that, feel free to, I think like Kathy said, this is a weekend seminar topic. You could do a weekend seminar on telehealth reimbursement, but I'd be glad to talk to anybody about that. But there are resources out there.
Okay.
Rob,
Here's the
like you said, ATA, American Telemed, right now knows the current legislation going on in a lot of places, and some of the legislation that they're interested in the funding, right?
Yeah, I think they actually have on their website, they do have an updated list. And if you want, I will send that in the follow-up email out to everybody. I'll include a link to that site as well, of course.
Yeah, and another thing that the Office for the Advancement of Telehealth funds are regional telehealth resource centers. And those resource centers are great resources, especially for micro-level data in your region or in your state. And so if you go to the Office for the Advancement of Telehealth or even do a Google search on telehealth resource centers, you will find that information. And I know that we're a part of the Mid-Atlantic region, which has got great resources, and I know most of the other ones in there are very helpful.
Okay, great. Here's another one. Where do I start when looking for partners to collaborate with our organization? We operate clinics in rural East Tennessee and would be interested in providing access to specialist consultants in these communities.
Oh, goodness.
Can you say the question over one more time?
Where do I start when looking for partners to collaborate with our organization? We operate clinics in rural East Tennessee and would be interested in providing access to consults.
So I guess my thought is you have the primary care clinics. You want to reach out to medical specialists to deliver a higher level of care in those areas. I would begin with your academic medical centers. I mean, you may start with your regional hospitals. You know, your regional hospitals are going to have a level of specialty care. If you're talking about, true medical subspecialty care, you're probably going to want to look at reaching out to your academic medical centers, East Tennessee State, Vanderbilt, UT. Again, and that's an area that I'm a little bit familiar with, so I would be glad to, if somebody wanted to talk to me offline, I'd be glad to maybe try to point you in the right direction.
Okay, great. Here's an interesting question. Can a practice of two people start this type, can a practice of two start this type of telemedicine program, get grant funding, and still operate like a regular LLC, or is there some sort of nonprofit attachment for grant funding?
In a practice of two, I think one of the answers that I mentioned earlier, probably correct me if I'm wrong, Rob, or add on here, is probably still an adequate answer is most agencies are eligible for different types of grants, but you do need to collaborate. And in some cases, you would need to be working with a nonprofit, especially some of the federal projects that require a nonprofit to be the federal fiscal agent.
Kathy, Kathy, I think you're right, Kathy, that unless you went to, what I would consider maybe the non-traditional source, something outside of federal agencies, the federal agencies are certainly going to want the lead agency to be a nonprofit. But I think you can, but certainly you could partner with nonprofits, and I think you could also look at foundations and chambers of commerce. There are all kind of opportunities because if you work in a two-person practice, especially in a rural community, you understand the economic, not only the economic benefit, but the economic mandate of having community-based health care. And so I think you could certainly raise interest in your program doing telehealth to keep more patients, more revenue in your home community, which is only going to lead to economic development. So, certainly look at partnering with nonprofits, but if you kind of stand out there alone, I think you should look for other opportunities for funding, and I think they're out there.
Yeah, and economic development are good buzzwords, as well as rural development if you happen to be in a rural area.
Here's another question about a rural area in Maine. We are located in rural Maine and experience a great deal of barriers for coverage, but have been told this is driven on a federal level as well. What groups would you recommend we become part of to help drive that catalyst of change you talked about to address Medicaid changes?
Well, so you want to make changes in the Medicaid, again, state level. Really, there's a lot of data of what other states' Medicaid programs have done. And I got to tell you, I'm embarrassed to say, guys, I thought Maine had done a lot of work with their Medicaid program because I used to know many, many years ago the people that run the Maine program. I would be glad to talk to you and map out what we did, but it is heavy lifting, talking to legislators, talking to your state Medicaid program. If you're in a Medicaid managed care environment, you talk to the MCOs. But let me tell you guys, if I can do it, anybody can do it. So there are certainly organizations, ATA and CTEL, and I think that your telehealth resource centers are going to be critical partners in this. But I'm going to tell you it can be done, and I think you'll find that state legislators are more receptive to this idea. And look, if nothing else, go to your state legislators and say, hey, if Kentucky can do it, why can't we?
Okay, let's see. What is the range of the cost to the patient to provide telemedicine service between a physician and a patient in a remote location, including the cost of network, broadband connection, telemedicine equipment, staff, etc.?
We need way more time for that.
Yeah, I think that's more on the patient side.
Now, the way they frame the question to the patient, there's no cost to the patient. Right. The patient pays their copay just as they would normally pay. The burden of cost is going to be on the healthcare facilities, and then it is up to them to generate revenues to help pay for that. So from a patient perspective, it's just like going to the doctor, except you don't have to get in the car and drive 2 or 3 hours.
Okay, I think that pretty much covers most of the questions we got here. And any others that have come in that we might have missed, we will be sure to include that in the follow-up summary email that we send. Also to note, the archive presentation will be available within a few days, so probably by Thursday we'll have that up on our website, as well as send you a link to it in an email, and we will also include a summary of the questions asked today and the ones that we missed, and we'll include some of those telemedicine resources, of course, that Kathy went through on her slides, as well as the few others that we mentioned, the ATA, telehealth resource centers, things like that. Thank you for attending. We hope you got a lot out of this, and we look forward to hearing from you. Thank you.